Okay, hello and welcome everyone to this webinar. It's so great to see you all here virtually. The webinar will start in about 30 minutes from now. So please feel free to share where are you watching this webinar from in the chat box. And even during the webinar, please feel free to share your comments and your questions in the chat box so that we can discuss them and take them up during the discussion session. And also, I hope that you know about the news initiatives and the news websites. Please feel free to visit my website, and also please you can also access my previous webinars on my YouTube channel. Please do subscribe to my YouTube channel as well. I will be sharing the link to my YouTube channel, and I hope that you will enjoy this wonderful lecture by Professor Daniel Walsh. He's one of the most eminent cerebrovascular neurosurgeons, and he's a consultant from the King's College London. I hope that you will like his to it's basically a matter of huge honor to have him with us today for the webinar. So I hope you will like it. And tomorrow we are going to have a talk on cerebral avians by none other than Professor Farashad Nato, and he's such an ace of cerebrovascular surgery, and I'm so deeply obliged that he spared time from his very busy schedule. As you know, that he's usually very busy in conducting all the workshops all around the world. So it was a huge privilege. It was so surreal to have him with us with us for a lecture on cerebral AVMs. And I will be sharing the link to that talk tomorrow, and hope you will like it as well. So thank you very much for your participation, for your interest in the new webinar series. And please feel free to share where are you watching the webinar from in the chat box. Okay, hello, thank you very much, Dr. Nasiru. Greetings to Nigeria. I have got so many colleagues from Nigeria, and also had some colleagues during my first one college tenure. They were from Nigeria, and I used to share our experiences in spine surgery. So it's great to have you here, all of you. So please feel free to share your questions and your comments in the chat box. Thank you. Hello everyone. We will be starting in about 17 minutes from now. So please feel free to visit my website in the meantime and also subscribe to my YouTube channel. You can access all of the recordings on my YouTube channel. Please to subscribe to keep update to receive my updates so that do not miss any of the future webinars. Many of them are of great interest to you and as they're of great interest to me as well. So I hope that you like all these webinars and hope to see you in future webinars as well. And also, please share where are you watching this webinar from. And it's fun to meet together, to attend and learn together in a very wonderful and comfortable and environment virtually on Zoom. So again, so happy to welcome you all here. Thank you. I hope that all of you know that all of these webinars are followed by a quiz. This time the quiz is, I've always tried to make it an easy, yet a helpful quiz. It will be, MCQ based quiz made using the Google Forms. All you have to do is to submit the quiz, and I'm not going to consider any type of passing percentage because it will be non-graded. It is just for, your own practice and for your own learning. So you all have to just submit the quiz by the end of the session. I will be sharing the link in the chat box. And after submission of that quiz, you will receive your certificates directly in your email. And please do let me know if you don't, okay, Professor Wash is here already. Hello, sir. Hello, sir. Thank you very much for joining us today. Hello, sir. Can you hear me?
Hello, can you hear me?
Yes, sir. I can hear you. Thank you very, very much for joining us today.
My pleasure.
Uh, so we can hear you, but actually, you cannot see you. Thank you very much for turning your video on. Thank you very much, sir, for joining us today. I know you have a really busy schedule. It means so much to us to welcome you here today and to have this privilege of learning from you.
Not at all. It's an honor.
Thank you very much. Our honor and pleasure is all ours. Thank you so much for joining us today. So, would you like to test your slides?
Sure.
Thank you very much, sir. Sir, we are a great fan of yours, and I remember all the programs that you conducted during the COVID-19 pandemic. And I would always try to attend as many of them as possible. They were so amazing and so great, sir.
Oh, thank you. It was a difficult time for everybody, wasn't it?
Exactly. I think that it was a very dark time, and I wish that something like that never happened again to anybody in the coming years because it was at that time it looked very hopeless, but we were quite encouraged because of people like you, especially because I was a trainee back then. I was about to complete my own training and my own residency, so I was back then we were so discouraged and disheartened that we might suffer, but it was all thanks to people like you, the mentors like you, who kept on training everyone virtually. And no matter where we were from, it meant a lot to us. It means a lot to us still. Thank you very, very much, sir. You were a hope of light. You were a light of hope for all of us back then, and still now.
Thank you. I had no idea, but that's really nice to hear. To be honest, it was doing us as much good as it was doing anybody else listening, just to feel that a little bit of normal life could go on.
it was a quite, it was quite normalcy back then. And many of my fellows, many of my friends were in quarantine back then, and they were still watching those programs and webinars. It means so much. It was the only window to the normal life, to see everyone on Zoom, seeing doing things like this. And I think it revealed so many people and the dedication of teachers like you. It was very challenging time, and it was like at that time I got a lot of inspiration from so many people, and I think that would always help me to have a much better view of our field. So thank you for all that you have done and you are still doing.
Not at all.
So we can see your desk, your screen now.
So you're able to see the slides okay, are you?
Exactly. Yes. Yes. So we can see it. So I hope that you do have videos as well. Would you like to test those videos right now? Okay. Yes, sir. It's working so perfect. So thank you very much.
Hopefully, experiences like COVID made us all very a bit more expert in managing things like online video. So hopefully the quality will be good.
Yes, sir. Sir, at one time it felt like we are connected finally, like connected to each other, and it meant a lot because we had that privilege of learning directly from the masters, no matter where we were from, especially for the trainees from low middle income countries where still neurosurgery is in infancy. It was like it was so unbelievable to learn from masters like you, to learn from the experiences, to learn what's happening on the other side of the world. Because, many of the trainees, they do not even afford to travel abroad because they have jobs over here, they have training remaining with them and everything, all those commitments, and obviously traveling issues as well. So it was like a very golden chance, a very lucky golden ticket for them to have this privilege of learning virtually. And it was something it was a good, I won't say something good about COVID-19 because it was a very dark time for all of us, but it was some sort of a ray of hope and something like this that was the only good thing about COVID, that we were able to have this, to reveal this, to explore this platform of virtual learning. So again, thank you very, very much, sir. Sir, would you like to start now? Because I know you have got a very busy schedule ahead. If you like, you can start now, and because most of the time attendees will keep on attending, will keep on joining us during the meeting, and there are also attendees on neurosurgical.tv and on my Zoom channel who are watching it live on YouTube and on neurosurgical.tv. So if you like, I know I don't want to keep you like holding you up on
No, no. We can start when you advertised. It's fine. I just wanted to log in and make sure the technicalities are all worked out, which they seem to be fine.
Thank you very much, sir. But I think that we can start. We have got about 9 minutes. For it's like 6:51 p.m. in London, I guess. So I can just. I really wish to give a very brief introduction. For you. Just and all of us know you so well, and you don't need any introduction. But I just really wish to give a very short introduction. For it's my own wish. And sir, would you like me to record this meeting?
You can do as you wish. It's fine. It's yours to use how you want.
Thank you very much, sir. Actually, I always keep my recordings so that if anyone miss the meeting out, so they can just go and check it out because I've got attendees from all over the world, and they are all always so interested to see the meeting. Sir, I really wish to proceed with a short introduction for you, and then, sir, I would like I would like you to then start your lecture, and I hope that Candice will keep joining us during the show. So I just again want to thank you very, very, very much because it is so unbelievable, and we are also so excited to have this privilege of learning from you. And I guess that we also had. I also wished you to deliver a lecture on spinal vascular malformations. Sir, we have also conducted a workshop here in Pakistan, and conducted live surgeries on spinal AVMs. It was kind of, hybrid type of surgeries. We first embolized those AVMs and then proceeded with surgical excision. So it was very exciting for many of us because many of us were able to witness how to operate on spinal AVMs. But today's we got this privilege of learning from you. So again, it's a matter of great honor and pleasure to welcome Professor Daniel Walsh today at the news webinar. And he's a consultant neurosurgeon at the King's College Hospital. I would say the esteemed institution of King's College, and he is an expert in cerebrovascular neurosurgery. He has served as the Regional Training Program Director for Neurosurgery and as a co-director of the Neurovascular Surgical Fellowship Program at the King's College. And it was the first such fellowship to be accredited by the Royal College of Surgeons of England. He has served as president of the British Neurovascular Group and presently sits on the board of the European Association of Neurological Surgeons Vascular Section. In 2017, he was appointed the clinical lead for the NHS England Specialised Commissioning Transformation Project on non-traumatic intracerebral and subarachnoid hemorrhage, and he's an advisor to the NHS England High-Risk Low-Volume Neurosurgery Working Group, as well as visiting clinical senior lecturer at King's College London. He's currently the associate editor for vascular and skull-based surgery at the British Journal of Neurosurgery, as well as carrying out reviews for many other of major medical journals. And many of us have read your articles and your wonderful work that is a lot of inspiration for all of us and a lot of learning. So again, sir, thank you very, very, very much for sparing time from your very busy schedule for delivering your wonderful lecture with us today on brain arteriovenous malformations, the technical considerations when operating on beam brain AOEM. So thank you, sir. The floor is all yours now. And again, sir, take as much time as you like because we will love to hear everything that you will be sharing with us. So again, thank you so much for joining us.
Okay, well, thank you very much for a very, very warm welcome. As I said, it's an honor. I'm conscious you've had some really esteemed speakers on this platform, and it's a privilege to follow them. And thank you as well for asking me to talk about a subject that I love and has been consistently the most satisfying aspect of my career. Which is arteriovenous shunts of one form or another. And when what I'm going to do is focus on the talk really on the technical aspects of the operation. So I'm going to invite you to accept that we've already decided to do an operation on an AVM. There's a whole subject centered around making that decision, and I'm going to touch a little bit on the decision-making process, but I'm not going to focus on it too much today. I will, of course, the operation begins before you enter the operating room, and some of the perioperative management I think is very important too. It's timely for me to be giving this talk because I've been invited to give a talk at the upcoming EANS Congress in Sofia later this year, where hopefully maybe I would see some of you. And the topic they gave me is, what have I learned from operating on AVMs? I guess you know you're getting old when you get invited to give talks like that, don't you? But that got me thinking about what I've learned. And of course, the first thing that comes to mind is that I'm still continuously learning from these lesions. It never really ends. But this talk this evening really is my first effort to assemble those thoughts together. So maybe if we start, and I'm not certain, at what level everybody is at in terms of their practice, in the audience. So I'll assume there's a range, but I'm going to define very carefully what exactly I'm talking about. Now, broadly speaking, cerebrovascular disease can be split into lesions that have an arteriovenous shunt, where you've got blood flowing directly from arterial to venous system without passing through a capillary bed, and lesions that don't, for example, cavernomas. And the particular form of arteriovenous shunt I'm going to talk about is the arteriovenous malformation. What's playing on the video there is an arteriovenous shunt, but it's not an arteriovenous malformation. You may recognize it as a dural arteriovenous fistula, but the absence of an interposed nidus sets it apart from the arteriovenous malformation. Which is characterized by this nidus coming from the Latin for nest, which is a collection of dystrophic vessels and shunting arterioles, as well as arterialized venules at its periphery that are characterized with markers of vascular maturation like endoglin. And these niduses can be compact, they can be more diffuse. There's a term that's sometimes used in association with diffuse nidus called proliferative. And the reason I mention it is it's not to be confused with another pathology called cerebral proliferative arteriopathy, which does not have an arteriovenous shunt usually. Now, the importance of understanding a bit about the nidus is that it's a conduit for a lot of blood flow over a long period of time because these lesions develop early in life. And it has an effect on the surrounding normal capillary beds. So the capillary beds surrounding a nidus may be immature. They may have deficient cell membranes, lack podocytes, but still are en route to irrigating functional cortex. And we'll come to why that matters a little bit later in the talk. As I said, the decision whether or not to operate on an AVM is a very nuanced one and very important. When an AVM has ruptured, it's relatively clear that some form of treatment is needed. We have lots of different tools at our disposal, but I would submit that when it's appropriate, microsurgical excision of an AVM offers the path to cure most quickly in the most cases. And that allows us to mitigate this really terrible natural history in a ruptured AVM, with about 10% of people losing their lives with each hemorrhage. When we come across, as we increasingly do, an unruptured AVM, the decision making gets considerably more difficult. And again, we could spend an hour talking about the evidence, such as it is, to support our decision making with an AVM that has not as yet bled. But in that situation, you're going to be able to fall back on maybe a wider array of treatments than might be advisable with a ruptured AVM. And when it comes to deciding how you're going to manage an AVM, a point I keep coming back to is it's so important to plan a treatment that will completely obliterate the arteriovenous shunt. These are not tumors. You can't make them a little bit smaller and mitigate their effect. In fact, it's conceivable that leaving a smaller AVM that's still shunting might create an environment that's more prone to hemorrhage than it was before by changing the hemodynamic stresses on the blood vessels. So I want to, come back, introduce this concept of shared decision making, which will be familiar to some of you, perhaps not to others. It's still something that we're learning about in my healthcare environment, but I think it's really important in diseases where we have an array of options and there is disputed evidence as to which are optimal. And like Sir Astley Cooper once said, the best surgeon, like the best general, is he who makes the fewest mistakes. But I would emphasize that we are all human and we all make mistakes. It's our capacity to learn from those mistakes that really define us. So this choosing wisely idea, I think, was initially put about by the American Internal Medicine Foundation. But it gained traction around the world, including in the UK, where the Royal College of Surgeons have promoted it as an idea. And what we're asking physicians to do is really consider the patient an equal partner in the decision to embark on a treatment. And it's not so much our job anymore to say, this is what you should have, this is what you shouldn't have. It's more our job to educate our patient to the point where they are empowered to make a decision for themselves. And that every patient should be invited to learn the benefits, the risks, the alternatives to any treatment, and also what it means if you simply don't do any intervention. For some people, that will often be their preferred way forward. And this is so important in relation to AVMs because of that aforementioned disputed evidence. You will probably be familiar with the Aruba study, which was a controversial but laudable attempt to get evidence to help us direct therapies with unruptured AVMs. You may be less familiar with a study called CIVMS, which is the Scottish Intracranial Vascular Malformation Study, and is a population study that essentially found similar results to Aruba in a very well characterized population in Scotland. Um, these studies have come in for very heavy criticism that I'm not going to rehearse here. I don't think the question as to what we best do with an unruptured AVM has been answered as yet. But I think they taught us some very important lessons, or at least reminded us of them. And the first is that the treatment of AVMs, however you do it, is associated with significant upfront risk from the patient's perspective. And it calls into question how realistic we are in estimating those risks for patients. And to what extent does our institutional volume and our individual volume and outcome affect those outcomes? It also tells us that we fail to obliterate AVMs frequently out there in the real world. Whatever the literature says, we do not cure AVMs as frequently as we claim to. Why is that? Is it because we're choosing the wrong type of therapy? Are we choosing the right therapy, but we're not executing it well? Or do we simply not have effective therapies? And I remind you that Aruba was a study that really underused, if anything, as was the CIVM study, microsurgical excision. But there are lots of things that move a physician and a patient towards a treatment that's not surgery, many of them emotive. But the one thing that often gets forgotten in AVMs is the importance of completely removing the lesion. And until we define our outcomes measures very, very clearly in studies, it will be difficult to answer questions about optimal treatment. So we must set the benchmark as the complete treatment of the AVM. And here are just a few of the things that tend to nudge all of us towards less evidence-based practice. There's a great many things ranging from institutional to individual patient or even doctor factors we have to weigh in. We may have become fearful of litigation. We may have time pressures placed on us that make us choose expediency over efficacy. And of course, we're all subject to marketing, whether it's from medical industry or from doctors talking on the internet about what they think the better forms of treatment ought to be. These are all one form of marketing or another. So we have to develop our critical faculties, and we have to constantly review our own practice and make realistic assessments of the evidence that we're presented with for the benefit of our patients. We do have tools that can help us make these decisions, and they're increasingly well validated. Starting with the time-honored Spetzler-Martin scale, refined here into this three-tier Spetzler-Ponche system, which has stood the test of time as a means of estimating both the efficacy and the risks of undertaking an AVM operation. But over the years, there have been many attempts to really try and increase the granularity of that middle group, Class B Spetzler-Ponche or Spetzler-Martin 3, where we recognize there are grade 3 AVMs that can be treated very effectively with surgery, but there are grade 3 AVMs that are far more difficult and are closer to class C lesions. So I think of all the systems we could talk about, the one that I've integrated into my practice is that proposed by Michael Lawton's group, the Lawton-Young system. Partly because it's user friendly and it relies on taking something from the Spetzler-Martin grade and then adding to it a little bit of granularity based on the age of the patient, A, B, whether the AVM has bled or not, and C, is the nidus compact or not, and giving points weighting for that. And that helps us just get a little bit more granularity. And I also find that it offers a more conservative estimate of risk in most cases, which I feel it makes me feel better when I'm talking to the patient. I like to under promise and over deliver if I can. I draw your attention there just to the fact, if you noticed when we were talking about Spetzler-Martin grade 2s in the original system, we were talking about a risk level up to about 9%. You can see the difference once you start adding weighting in for these three factors, that it increases quite a bit. So it makes a difference, and I think it really helps me decide how aggressively I want to be with some of the more complex grade 3s. The Spetzler-Martin grade and the Lawton-Young supplemental system do not necessarily apply to other modalities of treatment, though. And in particular, I'm thinking of radiosurgery. The good news is, though, that there are grading systems and models in radiosurgery that are reasonably well validated as well and can help estimate the likelihood of success as well as the likelihood of complication. So we try and integrate these systems into our risk evaluation for patients and come up with a balanced judgment as to whether surgery might be the right treatment for them. A really important point I will keep coming back to for the remainder of my career, and that was really emphasized to me as a fellow and a trainee before that, is that an AVM it's not a tumor, it's not disordered anatomy alone. It is also disordered physiology. And the importance of that is as follows. That perineidal system, where you have these immature, relatively leaky blood vessels, will be the conduits that are responsible for taking over the excess blood flow from hypertrophied blood vessels when you take a nidus out of the equation. So there's a redistribution of blood flow when you block the flow through the nidus. And those immature capillary beds, because they lack those basement membranes, lack those podocytes, are prone to leak or even hemorrhage. And this may be the origin of the so-called normal pressure breakthrough phenomenon. It goes by many names. Morgan, my old professor in my fellowship, referred to it as arteriocapillary venous hypertensive syndrome. But the term that's always made the most sense to me personally is occlusive hyperemia. Hyperemia developing because we've blocked off the route of flow that was there before. So we have to be conscious of the changes we're making in flow within the nidus when we're intervening in any way, whether we're embolizing or we're operating. Because at its core, the nidus is not this inert lump which is connected to just the arterial system in multiple places. For the most part, it's made up of arterialized venules, and there are arterial pedicles irrigating it and venous pedicles draining it. When we fail to maintain a balance between the inflow and the outflow in that system, we risk tipping it into a place where it swells, leaks blood, or overloads too quickly those immature capillary beds around it. So the larger the AVM, the greater the amount of flow through that system that we have to consider. Those of you who've seen operations on AVMs will have noticed that the inflow, the arterial pedicles, will often be far, far larger than the equivalent normal blood vessel. And this leads to a phenomenon whereby there's a very high sump pressure in these vessels close to the nidus. So the closer you get to the nidus, the greater the end pressure in the cut artery is. So if possible, we want to try and open up the arachnoid spaces around the AVM and allow ourselves to interrupt the larger arterial pedicles a little bit away from the AVM to avoid this phenomenon whereby the pressure in these arteries remains very high after the nidus has been removed, but take it back far enough without embarrassing normal healthy cortical flow that the pressure can be dissipated into more of the normal arterial bed than would otherwise be the case. Naturally, that leads one to think that perhaps lowering the systemic blood pressure might be an effective way to mitigate the redistribution of blood flow around the AVM. And this has been something that's been focused on by a number of groups, the best known perhaps being in the Mayo Clinic led by Thorolf Sundt. And this was the protocol we used in Sydney under Professor Morgan, where we had a very aggressive CPP-directed protocol to lower blood pressure. In fact, ultimately, this was found not to be beneficial in most cases. It was likely to be more beneficial in very high-grade AVMs, the Spätzler-Ponche class Cs, which in fact are the ones we're probably least likely to want to operate on because they're associated with such high morbidities. The Helsinki group have a protocol as well, which is focused more on the systolic blood pressure, and I think is directed towards mitigating the beat-to-beat variation in blood flow. They don't use barbiturates and other adjuncts as are used in the Mayo protocol. It's a little bit physiologically gentler, I think. But again, they found it's really most helpful in grade 3 and above AVMs. So as my practice has evolved, I've gradually stopped using induced hypotension as a prophylactic in AVM surgery until I get into Spätzler-Martin grade 3 and above AVMs, at which point I will usually try to follow something akin to the Helsinki protocol, relying mostly on beta blockers. Another important adjunct one will be considering around the time of any surgery is whether to embolize the AVM. And again, here we have to remind ourselves, it's not a tumor. We are not necessarily looking to convert the nidus into a avascular lump, not least because that will immediately redistribute the blood flow into the normal surrounds, but it also converts a compressible vascular mass into something that is incompressible, hard, and we then have to work around, yet can't necessarily debulk aggressively in the way that you might in meningioma. Whether embolization actually improves surgical outcomes in AVMs is somewhat contentious, and a lot of very experienced authors have gradually moved away from very aggressive embolization as part of their normal practice. I certainly like to coordinate very carefully with the interventional neuroradiologists I work with and target what it is we want to achieve. Usually that means targeting arterial pedicles that are difficult to get access to, but avoiding very aggressive nidal penetration and creating big, hard lumps that we then have to struggle against during surgery. We also try and make the changes in flow slowly. So we'll usually restrict ourselves to about one arterial pedicle as a rule of thumb per session, and maybe break it up over several sessions so we don't invite sudden changes. And I'll show examples of that. Any adjunct you deploy brings with it its own problems. And I don't know if you can appreciate what's happening there on that skull X-ray in an embolized nidus. What's happened here is the catheter has gotten trapped within the nidus along with the liquid embolic agent. So that catheter has to be cut off and left in a vessel. Early on in the operation, I have to find that catheter and cut it, because if I manipulate the nidus with that catheter in place, I risk causing a dissection somewhere along the arterial tree that it's used to reach it. So nothing comes without a cost, and we have to deploy these adjuncts carefully. Um, this is an example of that. This person has had a hemorrhage on this CT scan. You can probably appreciate that there's an AVM just here. This is the angiogram showing an occipital-temporal AVM, which we were looking to treat surgically, and ahead of that, elected to carry out a perioperative embolization. This is the same patient after a little bit of time has gone by, that blood clot has resolved, the swelling has gone down. So it's about time that we plan the operation. And if you look carefully at these images from the embolization, there's been an effective but modest embolization of the nidus, but despite their best efforts, can you notice there you can see embolic material within the superficial draining vein of this AVM. And in retrospect, that was important because although things looked reasonably good, there was good flow through the AVM, nidus appeared to be draining. Of course, this material, in fact, was generating thrombus, and that developed slowly. And unfortunately, in the recovery, when the patient woke up, it became evident something was wrong. And when you see a situation like this, and we obviously need to do an urgent decompressive procedure to save the patient's life now, um, you know you're going to be facing quite an angry AVM. You're going to be facing quite an angry capillary circulation. Because what's happened is we've started out with an AVM that recently bled. Why did it bleed? Well, often the reason is because its venous drainage was already maybe a little bit embarrassed in some way. Stenosis, thrombus, we often see these changes in veins. And that has tipped that balance between arterial inflow and venous drainage in a way that has increased the turgor of the AVM and made it more vulnerable to hemorrhage. Then we go ahead and we partially occlude the nidus, maybe inadvertently partially occluding some more of the venous drainage, but without completely taking out all of the arterial inflow. And the result of that then is that there is increased turgor in the nidus and unfortunately hemorrhage. So here's an intraoperative photograph which really illustrates all of the tools and tricks one has to wheel out to deal with that situation. Notice that on this hypertrophied middle cerebral vessel that was irrigating the AVM is here. This was that clot cavity we saw on the scan. Do you see there's two clips on this? Because it took two aneurysm clips to close this vessel with that very, very high stump pressure. Notice as well, I've got a retractor here, which I would advise you to always have standing by. And that retractor is compressing the main bleeding point of the AVM. I can see that the venous drainage, at least in part, remains patent. But this, if that was not there, there was a fountain of arterial blood issuing. And very, very quickly, you find yourself in a situation where you've lost a lot of blood and the patient may be somewhat unstable. It's very difficult at this point to know is the best thing to go ahead and do, be aggressive and try and get the whole AVM out hot, but you can see how difficult the operating conditions are. I always try and come back another day, if I'm honest. I've rarely seen these, a salvage or commando type resection of an AVM end well. So if at all possible, I will try and get the situation under control and return the patient to the intensive care unit to stabilize. And what you'll sometimes see then is that over a period of a few days, unlike other forms of intracerebral hemorrhage, with the use of things like induced hypertension, a floating bone flap in this case, we got to a point where that patient was beginning to show signs of recovery, perhaps about a week later, and the brain swelling was much improved. I rarely leave the bone flap out completely in that situation because, again, I think some degree of cover of a superficial AVM is advisable and is something I've learned is very useful for lots of reasons over the years. But if you can get to this point, you then have options to consider going back and treating the AVM electively and definitively. But let's say we've gotten to an operation in a controlled circumstance. Most AVM operations will be elective procedures. Even with a recent rupture, we know that you have a little bit of time to allow recovery. Even, if you have to evacuate a hematoma, you can leave the nidus and safely go back within a couple of weeks with very little additional risk, if any at all, to the patient and get much better operating conditions. And then we can make use of advanced imaging technology, things like tractography, um, something that increasingly we use that I think has a lot of promise in AVMs is transcranial magnetic stimulation to map eloquent cortex adjacent to it. Functional MR imaging is not very helpful with AVMs because it's echoplanar imaging and it relies on changes in blood flow to show its changes. So you can't really be certain what it looks like in a disease situation if you don't have a comparable baseline beforehand. And then, of course, we have things like ICG. Although, if available to you, I would always encourage one to rely on intraoperative angiography in most cases to see the complete picture in AVMs. Ultrasound too is super useful, particularly if you're dealing with a subcortical AVM and maybe you have a hematoma that requires evacuation first. But the strategy of dealing with an AVM, the one I was taught by Professor Morgan, is perhaps not the one that's best known. Everyone knows the dogma about taking the arteries first and leaving the veins until the end. Um, in fact, quite a lot of the time, people take what Professor Morgan used to call a neurogeographical approach to AVMs and would start circumscribing the nidus a little bit like a tumor without going deep into the arterial pedicles first. And really, what we want to encourage people to do is to aggressively go across the arterial pedicles of the AVM, usually heading for the deepest part of the nidus, perhaps the periependymal part if it's that large, but what he used to call the nose cone. And then avoid circumferential dissection of the nidus until you have brought those arterial pedicles under control, reduce the flow, and then begin mobilizing the nidus. So I thought I would illustrate that with a fairly straightforward case, and go through each of those facets one by one. And we're going to look at every aspect of this in this young man who's got an unruptured AVM but had presented with a seizure disorder. Um, Now there were this could have been managed conservatively. That process I described, of discussion with the patient, giving them time for reflection, allowing them to bring their own priorities into the decision, actually meant that this person felt safest having a planned procedure. And as you can see, there's a sizable but superficially drained, for the most part, AVM there, that we regarded as operable, and we thought that microsurgical removal would carry the greatest chance of completely curing it. So we grade this as a Spetzler-Martin grade 3. There is, in fact, a small deep draining vein, which you'll see later in the video. And the strategy to get to the nose cone, to divide those arterial pedicles, is going to require us to look very, very carefully at the angiography. There's going to be two phases to dissecting the nidus, what we call marginal dissection, which is where we have to stay really, really close, right on the nidus, and preserve the adjacent brain as much as possible, or zonal, where we can afford to enter the white matter and take the AVM within it. But the arterial pedicles here are going to be the ACA. So we need to access them by going down the interhemispheric fissure, not by circumferentially dissecting the lateral part of the AVM. The first place we need to go is into that midline so that we can locate the anterior cerebral artery branches irrigating the AVM. There are some peel to peel MCA supply, but most of the irrigation is from the anterior cerebral artery, and there is en passant supply to the leg area and supplementary motor areas by the ACA, which needs to be preserved as well. So the first phase of this operation is to expose the anterior cerebral artery along its length, and then begin about mobilizing the nidus and isolating the venous drainage. Position is going to be very key to achieving that. So we know there's a little superficial vein above that's going to impede our access to the main pedicle. So that's going to be taken down. But there are other veins that we can preserve that will drain the AVM effectively. Once we've divided those ACA pedicles, we will begin strategically mobilizing the nidus by dividing other veins, but always choosing a vein to continue draining the nidus and that we can ultimately pedicle the nidus on before its final delivery. Because we're going down the interhemispheric fissure, for me, the position I'm going to favor is going to use gravity to help open up the fissure a little bit. So my line of sight is going to be like that. Gravity is going to bring the hemisphere and the AVM down a bit. And the craniotomy, which should be generous and cover the whole peel representation of the AVM, but if I'm operating the midline, will always cross the midline. And you'll see why in just a moment. So here you can see there's an aneurysm clip on that superficial vein. This is the midline, and we're gone right across it, and you can see that we can now bow the superior sagittal sinus across the midline a little bit, and that allows us to open up the anterior interhemispheric fissure, or put a retraction suture to keep it open while gravity encourages the rest of the brain downwards. Now, we have embolized this AVM a little bit, but we have not done it aggressively, and that means that this is still compressible. So you'll notice that as I work here, we can press gently down on the nidus, work our way down the falx, take down any adhesions that are adjacent to the nidus on the way to where the anterior cerebral artery should be. Well, we know it's there. It's sitting on the corpus callosum. So we've got to get down that midline along the peel surface of the AVM. We don't need to fear it. We can control it, just very gently taking it down one adhesion at a time. And as you can see, we're not intruding into the AVM at all. So it's not swelling. It's not giving us a lot of problems. These are good operating conditions. We will, as early as we can, identify the anterior cerebral artery, not only proximally, but also distally. In fact, I often will start distally on the anterior cerebral and follow backwards. It's important to identify the other anterior cerebral vessels, including on the other side, and make sure that we don't get disoriented, mixed up between our right and left side. And it's only once we finally expose the whole anterior cerebral artery will I think about starting to take down the branches that are going into the AVM. Again, just to remind us a little bit, take a bigger bird's eye view. You can see how compressible the AVM actually is if we haven't turned it into a rock with our liquid embolic agent. We can control it. There's the distal anterior cerebral arteries appearing. We can follow those back to this anterior bit, and actually you're going to see part of the AVM that has been embolized anteriorly, that we know that there's one major branch going into the AVM at the front here, but this is all normal artery irrigating brain. But it's a little bit difficult to expose that branch because one of the venules is embolized. You can see it there, and that's hard to compress. So I've got to pull a little bit hard. There's a little bit of a flow aneurysm on here, but I've got to pull a bit hard to be able to access that branch and take it down. I've used an AVM microclip, which I think are a very useful tool to have in your armamentarium. But once I've skeletonized the anterior cerebral artery, now the AVM, if you look in the foreground, you'll see it's beginning to relax a little bit, isn't it? So that now allows me to take down one of the anterior veins, which I've done between a clip there, and start mobilizing the anterior part. I'll show another application of these AVM microclips. There's a number of situations in which they're useful. This, of course, is an aneurysm clip for the larger vessels. But small peel-to-peel vessels, the so-called red devils that can be very troublesome, AVM microclips will stop them retracting into the brain, which is useful. You can see there now the much more relaxed nidus is beginning to roll away from the forceps minor of the corpus callosum beneath. And that then allows us to start looking for that deep vein that we know is going to be anchoring it in there somewhere. What I'll be anxious to do is get a little clip on that vein too, again, just to avoid tearing it and having it contract into the white matter, bleeding in, where I can't see it and damaging that tissue. But we're not going to see it until we come across the peel-to-peel middle cerebral artery supply. And this phase is closer to a zonal resection because I'm having to just take a view of what's white matter I can enter in order to secure those MCA feeders into the AVM. And we've judged that it's safe to do that here, and then so that we can mobilize the remainder of the much more relaxed devascularized AVM, which we're beginning to pedicle on that posterior vein. You'll often find, and I'll show a picture of it a little bit later, that the very last thing holding an AVM in is a vein and an artery. So there's the deep vein going into the forceps minor. So just before I diathermy and cut that, I'm just going to put a little clip on it just in case it tears so it doesn't retract into the white matter and I then have to chase into the white matter to secure it. You can see that that's the classic picture that we want, isn't it? The blue nidus now, much more relaxed, all pedicled on that vein. And at that point, we know it's going to be safe to divide the vein. And there's that really satisfying moment when you can deliver the whole AVM on block. What was the so-called extirpation? Extirpation meaning complete removal of the AVM, which is our criterion standard for abolishing the whole AV shunt. And also, this allows us to see that the ACA there is intact. You can see the large draining veins going posteriorly have turned blue. And we'll do an ICG in just a moment that shows the ACA is functioning normally, and I'm happy to say the patient woke up neurologically intact. So that's the, if you like, the ideal AVM surgery, if you want. Towards the very end, you have a very, very careful look around for retained nidus, but that's the wonderful feeling of seeing the angiogram where the AV shunt has been completely abolished. And if we take all that care about the dissection of the nidus and the preservation of the blood vessels running on, the footprint on the brain around really can be very modest, as you can see from the MR. So just going back to turning a craniotomy in an AVM, I think one thing I've learned over the years is you've got to give a lot of respect to a superficial AVM in particular. And I draw your attention to this appearance if you see it on a CT scan, where there is scalloping of the skull by venous elements of an AVM. I think when you see that, you need to be extremely careful when raising the bone flap. My normal practice is always to drill slots over the draining veins peripherally, but when I'm raising the bone flap, especially if I see this, I proceed very, very carefully. I will even consider leaving an island of bone over a vein if it's adherent. And the reason is, in this case, there's just a very, very prominent central venous element of the AVM that I've left an island of dura attached to rather than try to dissect off. You can see how it's eaten into the bone there. I've seen examples as well where the dura is completely absent and you've only got vein sitting under your bone flap there. So it's so easy to injure the vein in that circumstance that one should be extremely careful, especially with superficial AVMs. Here's another situation where we have another helper. We have a hematoma. So this is a similar problem to that AVM I just showed you, except things are made a little bit more straightforward by the fact we have a hematoma that allows us to access the nidus more or less 360 degrees very, very quickly early on in the surgery. But in principle, this is the same operation. I have to secure the anterior cerebral supply first. So I make the same approach. I decompress the hematoma, sure, but that just allows the AVM to fall away even more quickly, and we can then secure the ACA territory and mobilize as we did with the other AVM. Things are not always that inviting. This is a little girl who's had a hemorrhage here in the recess of the lateral ventricle frontal horn, and the AVM is situated quite laterally, the hematoma more medially. It's irrigated by the anterior cerebral artery. There's a little branch going into a nidal aneurysm. It's a fistulous AVM that then drains to this small vein. The direct route to that AVM is straight through a lot of cortex, or on the ipsilateral side, you go straight down, but you get into the clot. It's quite difficult to get laterally. So we have an alternative here. We have to try and think about what's the shortest white matter course that we can take. And again, by exploiting the positioning of the patient, we can really improve our prospects a lot. And what we've done is we've gone contralaterally. So you see, by going across from the other side of the falx, we get a much more favorable angle towards the AVM. And you end up looking at this view with gravity carrying the hemisphere downwards without any retraction at all, a little bit of retraction on the ipsilateral falx and cingulum to lift it up, and then we can see very, very straightforwardly to the small nidus and draining vein on the other side and remove it. So one has to always think carefully about what the best trajectory to our arterial pedicle is going to be, and to try and minimize any intrusion into the brain if we can do so. If I could return to working on the nidus itself a little bit, when you begin dissecting something like this, which is obviously going to be a very challenging AVM for anybody, it's pretty daunting. Where does one start? The P arachnoid is often very thickened, particularly around the major draining veins. And when you've got a lot of superficial veins, it can be difficult to know really where to begin. The first thing I'd say to you is to remember that the arterialized veins are usually going to lie atop the arteries. So if you want to look for the arteries, you want to look underneath the veins. And in a case like this is actually really just a Sylvian fissure dissection, albeit one made very difficult by the presence of multiple large arterialized veins. And you're going to have to make a strategy whereby you can deconstruct some of those veins to facilitate the access, in this case, to the Sylvian fissure and those arterial pedicles into the AVM. This can be a slow process. I have a book somewhere in here that I think it's Dr. Spetzler's book, but there's a passage I always remember and I can never find, to the effect that AVM surgery is often tedious and interspersed with brief periods of apparently uncontrolled hemorrhage. And I like that description. I think the best AVM operations are sort of boring and tedious to watch, but just occasionally it can get a little bit out of hand. And here's a good example. What we're seeing there were those arterialized venules I'm going to come on to again now. At the periphery of the AVM, you do not have lots and lots of arteries embedding themselves in the AVM. When you come across one of these apparent arteries, if you dissect it out carefully enough, you'll actually see that it turns back on itself, and it is in fact a loop coming out of the nidus, going back into the nidus, and invaginating into the brain, as you see there. And you can sweep those arterialized venules out of the white matter relatively atraumatically. And you can see this is not an aggressively embolized nidus. We've embolized some of the deep elements, but we've been careful to preserve some of its natural ability to be compressed. And I'm not aggressively diatherming on these loops either, because if I do that, I'm going to gradually increase the venous resistance in the nidus. And if I keep doing it for long enough, the turgor will increase and make it more tense and more likely to swell and bleed. So although um, a slow process sometimes, working like this can really help you minimize the trauma to any adjacent brain. There's an embolized part of it, and I think that outlines quite nicely the architecture of those venules as they invaginate into the white matter. But you can see how it's actually a little bit more difficult to tease those embolized venules out of the white matter than it was the ones that were still alive. As I said, the last thing holding your AVM will quite often be an artery. I call this the artery of hubris. If you're ever wondering why your apparently completely pedicled AVM is still got blood flow in it and your vein is still red, look under the vein. You'll find a little artery, and there it is. That's the reason. Just occasionally, we will fall back on staging an operation. So this is a little bit controversial. I think it's got a place over the years. Lots of different authors have come and gone on the wisdom or otherwise of breaking up a large AVM operation into two stages. You can see this is that example I've just been showing you. But in fact, we did this over two stages. And we judged the turgor of the AVM using quantitative ICG maps, as you see here. And at the point, because we were deconstructing so many of these Sylvian veins, I wanted to be sure that if I was going to stop, I had not tipped the AVM to a point where it was now more tense than when I'd started because I'd embarrassed the venous drainage so much. Um, so the ICGVA just allows us to confirm that very gradually. Those deconstructing the veins you've already seen before, doing that a little bit at a time. And then at the point that I want to think about stopping, we run another ICG flow map and just compare it with what we started on to make sure that overall the nidus had become less congested, and it had in this case. So we can pack up at the end of the day. I've sent the patient back to the intensive care unit asleep with strict blood pressure parameters overnight, and this is what you find the following morning. We're able to restart the operation in very good operating conditions, relaxed brain, relaxed nidus, and now we can turn uh, our attention to the deepest part of the AVM with refreshed eyes and that's do this as atraumatically as we possibly can. And you'll see that there's the flow map towards the end, and that's one of our residents. I often say that the tremor on the clip here is not fatigue, it's excitement because the resident was putting their first clip on, and out comes the AVM. So, if I could show you another slightly non-standard approach to AVM surgery that we will occasionally deploy, it's this, which this is a young woman who's had a hemorrhage from this lesion in her pulvinar thalamus. You can see it there. There's a large draining vein draining into the galenic complex, and it's irrigated by mostly branches from the posterior cerebral artery. There's the formation of the vein. This is a very eloquent AVM. It was a difficult one for them to embolize. We did a microcatheter study, but the en passant collicular artery made it something that they felt was very high risk to try and embolize. There wasn't enough runoff for reflux. So for this, we looked at in situ disconnection. Now this is a technique that was originated by Dr. Spetzler and his team, initially for intramedullary spinal cord AVMs. What you require for this to work is that all the arterial supply and the venous drainage has to be accessible to you on the peeled surface. So for this AVM, we're approaching it through the lateral supracerebellar infratentorial approach. So we've got the patient in a three-quarter prone position. We're allowing the cerebellum to drop down. We've hitched up the lateral sinus, and we're under the tent here, following the trochlear nerve from lateral to medial, so that we can expose both the PCA and the SCA branches as they emerge from the quadrigeminal plate cistern. So there you see the trochlear nerve. We're moving. The midline is over here. We can see these larger vessels crossing the nerve. It's a little bit hard to work out what's PCA, what's SCA at this stage. But if we open all the arachnoid and expose all the anatomy, we get to a point where we see that clearly we can begin to appreciate the formation of the nidus above us. Yeah. So now we're close to the midline. The falx cerebelli is back here. We're able to take down all these adhesions, and by now you can appreciate we're seeing the bottom of the AVM with the vein forming here, heading up towards the galenic complex. So what we now need to do is be confident that we can address the whole arterial pedicle. And the arterial pedicle is coming towards us here from the ambient cistern. These are these PCA branches. We want to disconnect those as close to the nidus as we possibly can. We're using intraoperative neurophysiology that allows us to temporarily occlude the vessels and just reassure ourselves insofar as we can that no major bad result, nastiness results from that. And then we just basically take down these blood vessels one by one close to the nidus until we see that vein begin to change and soften. It starts very quickly, actually, in this case, once we take down those first couple of vessels. But the tentorium itself is limiting us a little bit. So we have to, before we take the vein, I want to be really, really sure we've gone completely across those little PCA afferents. So to help me do that, what we can do is we can open the tentorium as well. And that will just allow me to be completely confident that we're above the pedicle and there's nothing remains irrigating it that might cause some bleeding in a very, very eloquent spot. So we open the tent. It can sometimes be a little bit vascular itself, but usually not a problem. And divide it like so. And hopefully you'll see in a moment that we then get a really good view of the full arterial pedicle. You can see it there appearing already. And we were able to divide that, and it becomes pretty unequivocal that the flow through the AVM normalizes and the nidus softens. So there you see the remainder of the pedicle. I couldn't see that little branch going in beforehand, but now I can. And I have to be confident that I can access all of the contributors to this nidus if I'm going to not dissect the nidus out itself. And of course, that would be a relatively traumatic thing in the region of the thalamus. The ICG will help reassure us as well, although it clearly feels much softer already, so I'm pretty confident it's gone. See me squeezing it there. I'm feeling that we can do an ICG now and it will be reassuring. And there we go. We see no flow through the vein at all. So now I diathermy the vein at the origin of the vein, and I leave the remainder of the nidus in situ, and that is sufficient to completely occlude that AVM. There's the control angiogram at day 1. The native vessels are preserved. There's no AV shunt. And we repeated that angiogram 3 months later. Patient had some diplopia that resolved by 6 months. She had baseline heavy body sensory loss that was not worsened. So we've used that strategy in a few of these highly eloquent AVMs, both in the brainstem and the spinal cord, very effectively. And I think it's a really, really useful technique. So to finish up, I would summarize what I'm trying to say here, that if I've learned anything about succeeding with brain AVMs, it's that First of all, you've got to choose battles that you can win. And you can use these models that have been developed over the years to help us choose those battles. We also have to use adjuncts in a very considered way because they can add problems as well as remove them. Um, we have to deploy the other modalities with a view to cure selectively, and we have to be confident that that's the best option for the given situation. But we must remember the goal of treatment is to completely abolish the AVM. Partial treatment is not a good strategy. And if you do run into problems interprocedurally, you've got to be able to keep your wits about you and adopt a systematic approach to perinatal bleeding. Have retractors about you, tamponade the nidus, get used to working with the nidus itself, moving it around. Um, Recognize problems early, get out of the nidus, tamponade, stop, allow recovery. Um, and opinions vary on this, but I think heroic attempts to very quickly deliver niduses often can end badly. So before you commit to a maneuver like that, ask yourself or maybe ask a colleague, is this what I really need to do? Um, and all of us at any point in our careers need to remember to ask for help. I've asked for help recently myself when I was really tired towards the end of a big AVM, and my colleague was able to take it to the finish line for me. That's in the patient's interest. You have to leave your ego at the door and make use of your friends and colleagues as well. Young neurosurgeons starting out with AVM practice, it is difficult to establish yourself in practice a lot of the time. So that's certainly true in the UK. Um, High volume AVM surgeons from history, but that doesn't necessarily apply to your practice. Um, this is a paper I was involved with where we looked at the early years practice of graduating fellows from Professor Michael Morgan's fellowship, and he was historically one of the largest volume AVM surgeons. And what we found was that certainly for lower grade AVMs, it was possible to replicate outcomes in lower grade lesions if you had completed a fellowship in cerebrovascular neurosurgery for at least a year. Um, so it's possible to do, um, but it's something that you will build your experience on throughout your whole career. And to be honest, that's one of the fascinations about it. It's not something that will ever get boring. You have the capacity to really help people. You can cure them. You can take away not only the physical effects of these lesions, but the psychological burden that comes along with living with something that could harm you at some point in the future. And it's a wonderful feeling to be able to say to people that the AVM is now gone for good. So I will leave it at that. And as the slide says, if there's anything on there, there's a YouTube channel. Most of those videos can be looked at again in your own leisure. But if you've any questions or anything, I'll be very happy to take them now, or get in touch. Thank you.
Thank you so much, sir. And many of us, like I'm receiving a lot of messages right now in my chat box and also on my WhatsApp group, that many of us are thinking that what you have told us in your lecture is equal to about 3 decades of our postgraduate training and learning. Sir, you have shared so much to us and it means a lot to us. Sir, your lectures and all your videos and all the knowledge that you have shared with us throughout pandemic until today, sir. So it means so much because, like I have already mentioned, many of my own colleagues, I can see them, many of my juniors, even many of my seniors, they didn't have this privilege of learning skills and learning so much from masters like you. And, sir, it means a lot to have you with us here and to have you share your experience and teach us what you know and what you do so nicely with your impeccable skills. Sir, it means a lot to us. Sir, when I started my news network, it was like about 2 years ago, and it was my only passion was to promote free, accessible education all around the world, especially to those parts of the world where people are not able to learn and where there are a lot of people patients who are suffering. And sir, I don't know how to say it. I cannot find the right words to express how much it really means to me and to all the neurosurgeons, especially to those who belong to the low middle income countries and the developing part of the world, to have you deliver and share your knowledge and to spare your time. So I think that saying just a thank you is very, very small in comparison to what you have done for neurosurgical education and training for all people around the world and globally. It means so much. So thank you very, very, very much for this wonderful and amazing lecture, sir. There is also, sir, I know that you have shared some of your views on insight or disconnection of AVMs in critical parts of the brain. So would you like to share some thoughts on insight to disconnection of the AVMs? I think it will be of great interest for many of the attendees.
Yeah. Well, like I said, I think it's a really, really useful technique. And as a, we began using it as well in intramedullary AVMs, particularly diffuse ones. We've had really very, very good success with it in terms of physical outcome. Um, and from my generation, it was quite a wrench to get away from the dogma that you must take out the whole AVM. That's so deeply ingrained in me. It took a little bit of time, to believe that this would be a good idea. But if you really, really think about it, it makes success. It makes a lot of sense in selected lesions. It's not for every lesion, for sure. For larger parenchymal high flow AVMs, like I showed you earlier on in the talk, that's not going to be a good strategy. It's been tried in the past as well, but when you've got polyfistulous large AVMs with multiple pedicles, they're going to find a way back. So it's for selected small, usually diffuse lesions. And the key thing is, can you get access to the arterial inflow and the venous outflow on the peel surface? If you can do it. If the vein is draining deep into a critical structure, it's not going to work. And you're going to have to extirpate the nidus to completely shut that shunt down. And that's inevitably going to be more hazardous.
Exactly. Thank you very, very much, sir. And sir, is there any of your specific tips and tricks for like the pseudo diffuse AVMs and AVMs with having a lot of perinidal angiogenesis? So, sir, would you like to share any particular point or tips or tricks? I know you have said a lot of wonderful things during your lecture, but is there anything that you would like to add for such AVMs and for high grade AVMs, sir? Is there anything that you would like to share about that?
Yeah, the concept of neoangiogenesis around the periphery of a nidus is an interesting one because the term suggests that the AVM is a dynamic entity. It's a proliferating entity. But in reality, we see that that's not actually the case. They don't grow beyond, outside of their development in childhood at very great rates, certainly not in adults. So this, I sometimes prefer to think of it as a pseudo-phlebitic appearance at the periphery of AVMs, where it's not so much that these are new vessels developing, but they are small vessels which have hypertrophied in response to the local shunt. And the importance of recognizing them is that they may not be part of the nidus as such. So when you are defining the nidus, whether you are intending to physically remove it at an operation or whether you are making a gamma knife plan to treat the nidus, you need to be very clear on what's nidus and what's not nidus. What's not nidus, pseudophlebitic areas around the periphery are not nidus. Venous ectasias and parts of the venous elements are not nidus. So you don't necessarily need to include those into what you're resecting or what you're gamma knifing. Um, and that's something of a dark art sometimes. It's a somewhat subjective judgment. At operation in a large compact AVM, it'll often be distinguishable by the fact that you can clearly see that these pseudophlebitic vessels have clearly got cortex around them. There's not, the classical definition of a compact nidus is that there's no intervening nervous tissue between the vessels. But in these areas, there clearly is brain, and these hypertrophied networks are running through that brain. And I think therefore you have to be careful not to intrude too much into it. And you have to believe that this is going to be okay when you do your angiogram as well. So, as ever, a careful study of the angiogram beforehand, discussion with your radiological colleagues can help clear that up for you.
Thank you very, very much, sir. It's really an interesting topic, and you have made it so clear. I guess that everyone, sir, I've got a lot of wonderful feedback, and everyone is really impressed and really like everyone is in an awe to to listen to what you have to say. Thank you very much again, sir. Sir, there are a couple of questions also in the chat box. Would you like me to convey to you?
Yes, please. Yeah.
Thank you so much, sir. So there is a question here that just popped on. In case if we do microsurgery within days after embolization, we perform within days we after embolization we perform surgery. But in case we plan stereotactic surgery, we advise it after months of embolization. Why is that difference? And what is the best treatment choice in case of multiple AVMs?
Yeah. Well, opinion has come and gone and come around again on embolization plus radiosurgery, hasn't it? The group with the largest experience in my country of radiosurgery for AVMs are based in Sheffield, and for a long time they felt that really they would rather see an AVM with a view to radiosurgery before it's embolized. Because they felt that their obliteration rates were severely reduced when AVMs came already embolized. Um, Now, there's data has emerged since then that really challenges that view too, and some of it is around whether you can actually discern the nidus properly in the presence of a lot of radiolucent embolic material. Sometimes discerning where the nidus is can be a problem. There have even been theories, as to whether the embolic material itself might deflect or have an effect on the energy being delivered to the nidus you want to treat. I remember the famous French interventional neuroradiologist Jacques Mouret, uh, announcing in a meeting once he did not understand that why every time he sends one of his embolized AVMs to a surgeon, they have to take out the whole embolic cast to take out the little AVM in the center. Why don't they just take out the bit at the center? And of course, any surgeon will tell you it's not quite so easy, Professor Murray. You've got to get to that center somehow first. And I think the radiosurgeons have a similar problem. Um, but there is data that suggests actually you can achieve comparable obliteration rates. That's come out more recently. I think when we refer for radiosurgery, we will generally try and ask first. If there's been bleeding from the AVM. Our first choice is usually going to be to secure any arterial aneurysms or any acutely ruptured bleeding points endovascularly, and then take out the rest of the nidus if it's feasible and safe to do it. But if for some reason radiosurgery is our next option, we won't try and aggressively embolize the nidus before referring for it. We'll ask them to take a look at it first. I think that's the right thing to do. The nice thing about AVMs is it's a team game. You get to work with your colleagues in a really coordinated way, and early communication, I think, is really helpful to discuss these matters.
Thank you very, very much, sir. Sir, again, sir, I also want to add a little bit more, ask a little bit more about it. Sir, do you have any specific like tips and tricks to operate on those AVMs that have been pre-embolized pre-surgically? Do you think that there should be something like some of the specifications that you would like to see, some precautions that you would like to undertake when you are operating on such areas that have been pre-embolized more than what you have already mentioned?
Yeah, well, I think if your AVM is aggressively embolized, you've got to prepare for the possibility that it's going to be a difficult mass to dissect sometimes. If you're not familiar on operating on things, liquid embolic agents like onyx, it might come as a bit of a surprise when you first diathermy on these vessels because um, you will get crackling and popping in response, little bangs and whistles in response to the embolic agent and the elements of it. That can be a little alarming until you get used to it. Um, Arterial vessel, vessels going in the first few days after an embolization, because of the way the liquid embolic polymerizes, it's a cohesive, not an adhesive substance. And you will sometimes find that although the outside of the vessel is hard and you've got to cut through it, it's difficult. At the center, there may still yet be a channel with blood flow in it. And then that's difficult to embolize. Sorry, it's difficult to diathermy because the embolic material insulates it. But equally, you can't clip it because the clip won't compress the vessel. So what you've got to do is pull out a little bit of the embolic material at each end, and then you can clip or diathermy it. So there are little things like that are quite easy to learn once you're there. Um, Occasionally I've had to resort to debulking very aggressively embolized nidus in order to get to critical elements of it. That always feels like a potentially hazardous thing to do with deep or larger AVMs, but it occasionally is something one will resort to.
Thank you very much. So there is just another question. So, do you have any tips about identifying feeders?
Yeah, well, I think you identify feeders first on angiogram. So you study your angiograms very, very carefully. And for me, there are lots of systems, that you will read about. Um, Different, people think of these things in different ways. For me, the easiest way to think about an AVM and how its architecture is to try and identify the parent arteries and ask myself, where do those parent arteries normally live anatomically? So if it's the anterior cerebral artery, it lives in the anterior interhemispheric fissure. That's where I need to go and start finding it. If it's the middle cerebral artery, it's often the Sylvian fissure. So I know where to find it, and so on and so forth. So I define an AVM by naming the arteries that irrigate it, and then I name the veins that come out of it, and I go and locate those in their anatomical homes. Um, then, like I said, expose your craniotomy, and it'll look a little bit daunting sometimes, and you don't know what's an artery, what's a vein. Everything is pink, everything is throbbing. Um, so remember that typically on the cortical surface, the veins will be superficial and go across the arteries. So look for the arteries first underneath the veins. Start at the draining vein and open up as much P arachnoid around it as you can to get yourself started into the perinidal space. If you don't have a fissure or something that you can get started on, like the anterior hemispheric fissure, starting somewhere close to the main draining vein is a little counterintuitive, but it'll often yield good results and allow you to say, right, now I know where's arteries and where's veins and where's nidus, and I can start developing that plane.
Very nice. Thank you very, very, very much, sir. Sir, actually, I have an attendee. He's I think your fellow. He's called Dr. Uday Gupta Bharatiya, and actually he wants to say hi to you.
Hello, sir.
Would you like me to allow him to unmute?
Oh yeah, feel free.
Sure, sir. Dr. Uday, actually, he's quite excited. Actually, he was so excited to see you. So um he wanted to say hi. He said, "I want to turn my video on if you can just allow me." So I asked your kind request. So Dr. Uday, you can turn your
Hello. I think your microphone is off.
uh, Dr. Uday, kindly unmute yourself.
Hello, sir. Good evening, sir.
Good evening. Thanks for
Yeah,
listening.
it was I met you after a long time, sir. If you remember, I was there doing my observership with you.
I
It
do
was a very
remember.
wonderful. Yeah, I learned a lot, sir. Thank you. That was a very informative seminar, sir.
No, no, you're very welcome.
And applying some of your tricks also here. I learned how quarter like mini terionals and how to do a mini terional craniotomy for NC aneurysm and all that. That was
Yes, that's
wonderful.
they're fun. Well, that's good. Have you had success with that? Has it worked out?
Yes, yes. We started doing mini, and started with the aneurysms, basically mini terionals, and whatever I learned from your theater. So it was very wonderful, sir.
Oh, that's
I was
great to
waiting
hear.
for this talk also.
Yeah, I saw somebody asked a really good question actually in the questions there, which is there any room for leaving an AVM alone? That's a good question because the answer is yes, definitely. And that goes back to picking battles you can win. No, you know what, you're no use to anybody if you take on an AVM that we have learned the hard way over decades from people like Professor Spetzler that the outcome is likely to be poor. And that sometimes, unfortunately, the natural history is going to perform better than the best you can do. And we have to accept that. So absolutely, there's a place for conservative management of AVMs. There may, especially on ruptured AVMs, as I said, we have yet to conclusively demonstrate that treating them is consistently beneficial to the patient. So we should be very respectful of them and weigh very, very carefully our decisions to treat them.
Thank you very, very much, sir. Sir, thank you again for sparing time from your busy schedule. And sir, we are already so excited to have the honor of inviting you again.
Oh, that's all
So
right. No,
anything else? A reperfusion injury in an AVM, sir? What are your comments? Is it the leftover nidus or is it like any?
that's a good point. So if we're talking about reperfusion injury, we are saying we first have to demonstrate that the nidus is gone. So we have to exclude retained nidus. And retained nidus is probably, I think, a much more common cause of bleeding and swelling post-procedurally than normal pressure breakthrough bleeding, occlusive hyperemia, whatever you choose to call it. The second thing I would say is I suspect a lot of that type of swelling and bleeding too relates to venous impairment and normal venous impairment. And I'm reminded of a case, and this was a mistake I made that I shouldn't have made because I had learned this lesson previously. A small AVM that hadn't responded to radiosurgery and had hemorrhage years before, and it was a little bit diffuse anteriorly. I knew where the vein was forming. I could have taken the vein. My fellow actually was removing the AVM, and he said, "Shall we take the vein here?" And I said, "Take a little bit more. Take a little bit more vein, just in case we're missing something." That was the mistake, not his, mine. And so he took the vein a little bit more anteriorly, and later that night, that patient's temporal lobe infarcted, and causing a hemorrhage. And when we took them back to theater, what was striking to me is that the temporal veins were thrombosed, but there was no active bleeding. It was dry. So even though we had an acute hemorrhage, it was purely because the venous system had failed. And I think the venous system had failed because I impeded it too much. So I think that's another thing. You want to try and preserve the normal venous drainage of the brain around an AVM quite carefully, not be overly aggressive and take the vein. You saw how large some of those veins were in the examples I showed, but you've really got to take the vein as it originates out of the nidus, I think, to be safe and not precipitate thrombosis farther along that can be damaging. I've had a good experience, touch wood, with relatively low rates of occlusive hyperemia, lower than I might have expected at the beginning of my career. That may be because I've been lucky or I've been well educated. But I think it's actually an uncommon phenomenon. And I think a more common phenomenon is retained nidus and venous injury.
Thank you, sir.
Great, sir.
Thank you, sir.
Thank you. Thank you so much, sir. Sir, thank you very, very much again. I think we have taken a lot of your time, and thank you very much again, sir, for sparing time from your very busy schedule. And as I already said, sir, I think we are already so much excited to welcome you again, sir, whenever it is the most convenient for you.
Okay, I look forward to it. Thank you for having me. I appreciate it very much.
Thank you very much. Our honor and
Bye.
pleasure is all ours, and it means so much to us, sir. So I hope to see you again really real soon. And a big thank you from all of the attendees of this webinar, because I'm having a lot of wishes for you and for a lot of positive comments. And sir, thank you very much. We've learned a lot from you today, and it was a real privilege.
It's okay. You've got more AVM coming tomorrow, don't you? So keep the enthusiasm up.
Thank you very much, sir. Yes, sir. So Professor Prof.Daniel is going to share his view, and surprisingly, both of these webinars were like together just on adjacent days. I was a little surprised that he gave the similar date. So again, thank you very, very much, sir. We are going to have his experience too and your experience also. So it was like, again, I want to say that it was a privilege to attend your webinars, which were so exquisite, so amazing, so informative, that I think that I haven't attended so many of such teaching lectures throughout my whole career and throughout my own virtual attendance as well. So again, sir, thank you very, very much for your time, and it was a real privilege for us and for all of us who are watching it live and who will be watching the recordings.
Okay. Well, take care. Have a lovely weekend.
Right.
Thank you very much.
Good
Same
night,
to
sir.
you too.
Right.
Good evening, sir. Bye, sir.
Good night, sir.
Thank you so much, sir. Thank you, sir. Thank you, Dr. Day. Thank you, everyone, for your time and for your interest and everything. And I have shared the link to the quiz. Please submit it. It is a non-graded quiz, and you just need to submit it just in order to receive your certificate, which will be a personalized one. And stay tuned. We are going to have a lecture by Professor Farshad tomorrow, and thank you very much, Dr. Khalil Khan Zadran. Thank you very much for all your encouragement. I'm so happy that you all liked it. And I'm just sharing the link to my webinar tomorrow, and I hope you will like it too, because it's going to be amazing. Professor Prashadal is also he's an amazing teacher also, and he will be sharing his perspective. It was a real honor to have Professor Daniel Walsh with us today. Okay, so here's the link for the talk tomorrow, and please do get registered. And I hope to see you all tomorrow, inshallah, for this lecture by Professor Farshad. And if there are any specific topic that you want me to arrange a webinar on, please feel free to message me and just send your suggestion on the next topic. So again, thank you very, very much, and I hope to see you all. Thank you so much, Dr. Khalid Khan Zadran. Thank you so much, everyone. I hope that all of you have. We are having a huge thunder over here in Lahore, so I think that you might have some interruption from my side in the internet. So again, have a nice day, everyone. I hope that all of you have received the link to tomorrow's webinar and the Google form. So bye for now, and see you all tomorrow, inshallah.